So, hi all, I am Dr. Deepak, Senior Resident, Department of Emergency Medicine. So, today we will be discussing on the topic cyclic antidepressant overdose. So, we will discuss this topic under these headings. So, we will give a brief introduction to this topic and we will discuss on the pharmacology. In that, we will be discussing on its structure and its mechanism of action and its classification, and we will be discussing on toxicity of cyclic antidepressants and its clinical features, its diagnosis and treatment. So we will move on to the first heading, that is the introduction to the cyclic antidepressants, which were the first generation of drugs for the antidepressants, but their use for treating depression declined greatly because of the invention of the newer antidepressants like SSRIs, SNRIs. Also, cyclic antidepressants possess a narrow therapeutic index. Even though it produces narrow therapeutic index, at therapeutic level also it can produce toxicity. So, moving to the pharmacology, as the names, usually cyclic antidepressants are now called as tricyclic antidepressants because it contains 3-ring central structure plus a side chain. So, this is the normal structure. It contains three cycles and a side chain. So, cyclic antidepressants are divided into two categories, that is tertiary amines and secondary amines. Tertiary amines, because tertiary amines it contains 2 methyl group in the side chain, and secondary amines contains only 1 methyl group in the side chain. So, tertiary amines examples are amitriptyline, clomipramine, doxepin, imipramine. For secondary amines the examples are desipramine, nortriptyline, protriptyline, and other excluding to these two drugs are not included in both classification. Maprotrilline, which is a tetracyclic, that means it contains 4 cycles, that is 4 ring structure. Amoxicillin, the side chain differs in the amoxicillin. So that is, cyclic antidepressants are non-selective agents with multiple pharmacological effects, that is norepinephrine and serotonin reuptake inhibition, which is the main action of antidepressants. That is, serotonin and norepinephrine reuptake inhibition causes the antidepressant properties of cyclic antidepressants, and amoxicillin, which has an extra action, that is the inhibition of postsynaptic dopamine receptor. So we can remember it as, that is mechanism of action, we can remember it as blocks 3 receptors, blocks 2 reuptake inhibitors and blocks 2 channels. That is 3 receptors means muscarinic, alpha and histamine. 2 reuptake inhibitors means, that is norepinephrine and serotonin. Blocks 2 channels means sodium and potassium. So the image shows the same, that is the mechanism of action. In the first synaptic cleft it shows the 5-HT receptor blocker, that is the serotonin 5-HT receptor action, that is also 5-HT receptor reuptake inhibitor, that is serotonin reuptake inhibitor, and the second synaptic cleft shows the alpha receptor blocker, also the noradrenaline reuptake inhibitor, and the third synaptic cleft shows the muscarinic receptor blocker. So we can remember the multiple pharmacological action depending on the receptor. If it blocks the histamine receptor, it causes sedation and depressed consciousness. As we all know, antihistamines causes sedations, and antagonism to postsynaptic muscarinic receptor, that is anti-muscarinic properties, that is anticholinergic, it causes anticholinergic symptoms like hallucination, slurred speech, agitation, confusion, also tachycardia, hyperthermia, hypertension, and also it causes alpha receptor blocker, it causes sedation, meiosis, orthostatic hypotension, reflex tachycardia. Alpha 2 adrenergic receptor blocker, which causes mild hypertension, and also inhibition of norepinephrine inhibitor, that is increase the norepinephrine in the synaptic cleft. It causes agitation, mydriasis, tachycardia, hypertension, and also inhibition of the serotonin reuptake. That means it increases the serotonin in the synaptic cleft. It causes sedation, mydriasis, myoclonus, hyperreflexia. And inhibition of voltage gated sodium channels, it mainly causes cardiac rhythm disturbance, that is white QR complex, other conduction abnormalities, impaired cardiac contractility, Brugada pattern, ventricular ectopy, also causes hypotension. Also inhibition of voltage gated rectifier potassium channel, it also causes cardiac rhythm disturbance, that is prolongation of QT interval, ventricular ectopy, torsades de pointes. These are the main actions, pharmacological actions depending upon the receptor. You can remember it as through 3 receptors, 2 reuptake inhibitors and 2 channels. Then some other properties of the tricyclic antidepressants. Tertiary amines, that means it contains 2 methyl group in the side chain, especially blocks the reuptake of serotonin compared with the norepinephrine. It inhibits more, it helps in more inhibition of reuptake of serotonin. In secondary amines, more potent in blocking reuptake of norepinephrine. Tetracyclic maptotryline, we already mentioned, it is a tetracyclic. Which side chain is identical to secondary amines, hence it's more potent in blocking norepinephrine inhibition. Amoxapine, potent in norepinephrine reuptake inhibitor and also blocks the postsynaptic dopamine receptor. So regarding the pharmacokinetics, it is a highly lipophilic and achieve peak plasma in the 2 to 6 hours. And bioavailability is only 30 to 70% because of the extensive first metabolism, and it has a large volume of distribution ranging from 10 to 50 liter per kg. That's why it is not a non-dialyzable drug. It cannot be dialysable because of large volume of distribution. And cyclic antidepressants are eliminated almost entirely by hepatic oxidation. And clinical toxicity usually lasts longer because of the production of active metabolites. Example, if amitriptyline is metabolized, it forms the nortriptyline. Both are active metabolites. If imipramine is metabolized, it converted into desipramine. So both are active metabolites. So its action is prolonged. That is the that's all regarding the pharmacokinetics of cyclic antidepressants. Regarding the toxicity, life-threatening symptoms will occur if a person has taken more than 10 mg per kg in adults. If someone has taken more than 2.5 mg per kg, expected to result in some clinical toxicology based on the low therapeutic index of cyclic antidepressants. Quantity measurement of plasma levels of cyclic antidepressants is helpful in monitoring long-term drug therapy with therapeutic levels of 75 to 300 nanograms per ml for most agents. Desipramine associated with high case fatality. Regarding the clinical features we can remember depending upon the various action on the various receptors, also various reuptake inhibition. So it causes mild antimuscarinic symptoms to severe cardiotoxicity. A Glasgow GCS of less than 8 in the AD is a strong predictor of serious complications such as seizures and cardiac dysarrhythmia. If serious toxicity is going to occur, it will occur within 6 hours of injection. So at least we have to monitor the patient for 6 hours, which consists of that is severe toxicity consists of the following features, that is coma, conduction delays, supraventricular tachycardia, hypotension, respiratory depression, ventricular tachycardia and seizures. So secondary complication can develop from the cyclic antidepressants overdose. These include aspiration pneumonia, pulmonary edema, anoxic encephalopathy, hyperthermia, rhabdomyolysis. And seizures are usually generalized and are of a brief duration and occur with other signs of serious toxicity. So regarding the diagnosis, how will we diagnose a patient with cyclic antidepressant toxicity? It diagnosed by combination of 4 criteria, that is history of exposure, clinical symptomatology, characteristic ECG findings and a positive urine drug screen results. These are the 4 criteria for diagnosing cyclic antidepressant overdose. So in ECG abnormalities are common and helpful in identifying patients with increased risk of seizure and ventricular dysarrhythmia. The classic ECG with cyclic antidepressant toxicity shows sinus tachycardia, right axis deviation, prolongation of PER, QT, also QRS interval. And right axis deviation is demonstrated as a positive terminal R wave in lead AVR and a negative S wave in lead S1. That is this is an important point, that is in ECG there will be right axis deviation. It is demonstrated by positive terminal R wave in lead AVR and negative S wave in lead 1. So it is asked in most of the MCQs and also many of the questions. So this is the ECG. So in AVR, this shows the lead of AVR. AVR shows that is a terminal R wave of more than 3 mm. And also R bar S ratio is more than 0.7. This is a characteristic finding of cyclic antidepressant overdose, not cyclic antidepressant. Every sodium channel blocking property drug, if you take an overdose of sodium channel blocking property overdose, it will show these type of ECG changes. So this is a typical ECG finding of cyclic antidepressant overdose. There will be in this ECG there is a sinus tachycardia, QRS is wide, and also I have mentioned terminal R wave in AVR. So there is sinus tachycardia. Also there is a first degree AV block. P waves is not seen in other leads, especially P wave mainly seen in V2, V1 and V2. Okay. Also there is a broad QRS complex. These are the typical or characteristic ECG findings in cyclic antidepressant overdose. So the degree of QRS broadening on ECG is correlated with adverse events. If the QRS duration is more than 100 milliseconds, which is a predictor of seizure. If QRS duration is more than 160 milliseconds, is predictive of ventricular dysarrhythmia. That is, patient can go into VT in the coming period. And ECG abnormality develop within 6 hours of injection and typically resolve over 36 to 48 hours. And moving on to the treatment, first we have to prioritize the ABCD, that is airway, breathing, circulation and disability. So we have to put an airway if needed, put an airway means definite airway if needed, and we have to support the breathing and ventilation. We have to put large tube or IV cannula, start on IV fluids according to necessity. And disability, we have to assess the GCS, pupils and seizures. We have to continuously monitor the patient for any dysarrhythmia to occur. And also we have to identify the co-ingestion, because it is a cyclic depressant it is an antidepressant, so the patient may have a history of psychiatric illness, so we have to suspect co-ingestion. So we have to obtain serum acetaminophen level, that is paracetamol level and aspirin level, and urine catheterization for urine output monitoring, nasogastric tube for charcoal or stomach wash for giving charcoal and stomach wash. And patients who are initially asymptomatic may deteriorate rapidly and therefore should be monitored closely for 6 hours. So move on to the specific treatment, that is first is GA contamination, that we can give bowel wash, and also we have to give charcoal, that is 1 gram per kg per hour, maximum of 50 grams. So within 1 hour of injection, as long as airway is stable and patient is awake, then only we can give charcoal. If the airway is threatened, there is a chance for aspiration, so we should avoid charcoal. It may harm the patient more than benefit. So airway should be stable before giving charcoal. So initial treatment for hypotension or dysarrhythmia is sodium bicarbonate. It is 1 to 2 milliequivalents per kg IV bolus, and repeat bolus can be given, or we can add 150 milliequivalents of sodium bicarbonate to 1 liter of 5% dextrose and start at 2 to 3 ml per kg per hour. Sodium bicarbonate, which is one of the few indications for sodium channel blocker, that is sodium bicarbonate only have a few indications. That is, one of the indication is sodium channel blocker toxicity. So for dysarrhythmias, that is conduction abnormalities, QRS more than 100, we can give IV fluids, and we have to monitor serum electrolytes and also keep the blood pH 7.5 to 7.55. If the patient develops seizure or agitation, we can give benzodiazepine. Also we can give phenobarbital 10 to 15 milligram per kg if the seizure is refractory to benzodiazepines. And we have to avoid phenytoin, because it is a sodium channel blocker. It will exacerbate the symptoms of sodium channel, that is cyclic antidepressant overdose. So most seizures occur within the first 3 hours following injection and typically generalized and of brief duration. We can control the seizure with benzodiazepine. If not controlled, we can start on phenobarbital. So we should avoid phenytoin. And do not give physostigmine, flumazenil or phenytoin in these cyclic antidepressant overdose patients. And if the patient develops hypotension, we have to give IV fluids, that is 30 ml per kg. If not responding to fluid, we can start on norepinephrine or epinephrine. And case report suggests that we can give glucagon 1 milligram IV bolus also for refractory hypotension. If the patient develops torsades, dyspointes or refractory dysarrhythmias, we can give magnesium sulfate 2 gram. Also we can give 3% saline, because it is a sodium channel blocker. And we can consider lipid emulsion for refractory dysarrhythmias. So some of the drugs are contraindicated in the treatment of cyclic antidepressant overdose, especially sodium channel blocking property drugs, that is class 1 antiarrhythmics, class 3 antiarrhythmics, beta blockers, calcium channel blockers. These are contraindicated in the treatment of cyclic antidepressant overdose. And lidocaine has an unclear benefits in cyclic antidepressants induced dysarrhythmia, and there are no convincing data to support its effectiveness. So it's better to avoid lidocaine as an antiarrhythmic agent in cyclic antidepressant overdose. So these are the same ECG previously given, the same findings, that is sinus tachycardia, QRS complex wide with first degree AV block, and also that's a R wave prominent in AVR. So this patient, this is the next ECG taken after 1 hour. This patient has developed QRS widening has occurred. So after treatment, this is the ECG. So after treatment, patient's wide QRS has been settled, QRS duration has been settled. Also PR prolongation has been settled, also normal QRS width. In AVR R wave prominent R wave has come down. So after effective treatment, that is mainly sodium bicarbonate IV fluids, so after adequate treatment, the patient's symptoms has improved. So disposition and follow-up, how can we dispose? So as already mentioned, we have to, if the patient is asymptomatic, we have to observe the patient at least for 6 hours, and hospitalized patient can be cleared medically after they are asymptomatic with a normal or baseline ECG, normal mental status, and resolution of all antimuscarinic symptoms. And patient with intentional overdose require mental health evaluation. So that's all about the topic. So in summary, we have discussed about the pharmacology. In pharmacology, we have discussed about the structure of cyclic antidepressants, then its pharmacokinetics, its mechanism of action, its classification, that is tertiary amines, secondary amines, then other drugs, that is amoxapine and also miptrotylin. And regarding the toxicity, we have discussed on the toxicity, that is toxic dosage of drugs. More than 10 milligram per kg causes life-threatening symptoms, more than 2.5 milligram per kg causes toxicity symptoms, and clinical features depending upon the various action on various receptors, that is we can remember it as blocks 3 receptors, that is muscarinic, histamine and alpha receptor, and blocks 2 reuptake inhibitors, that is norepinephrine and serotonin, which is the therapeutic indication for cyclic antidepressant. It is act as an antidepressant because of the reuptake inhibition of norepinephrine and serotonin, and also it acts on, it inhibits 2 channels, that is sodium channel and potassium channel. Diagnosis based on 4 clinical criteria, that is history of exposure, then clinical symptoms, then ECG findings, and also urine toxicology screening positive. You have to remember the ECG, typical ECG finding of the cyclic antidepressant overdose. And regarding the treatment, we have to maintain the ABCD, and then sodium bicarbonate. It is one of the few indication for sodium bicarbonate in sodium channel blocking overdose, that is cyclic antidepressant overdose. Sodium bicarbonate is indicated, and also we can give for seizure we can give benzodiazepines. Remember, sodium channel blocking drugs, every drugs are contraindicated, like phenytoin, class 1, class 3 antiarrhythmics. So that's all my references. So thank you.